Okey. Nampak dah?
Okey.
Okey.
Okey. Okey, saya start balik ya.
Okey, boleh start.
Okey, saya start balik by the definition of shock lah.
Okey.
Shock is the emergency condition in which there is severe impairment of tissue perfusion which lead to cellular injury and dysfunction.
Okay.
And it need the early recognition and treatment lah, prevent the irreversible organ damage and tissue death. And if it left untreated, this patient can develop ischemic injury of vital organ leading to multi-organ failure. Next is ada phytophysiology lah.
Okay, nak suruh kita orang baca ke macam mana? Awak nak explain ke?
Hypovolaemic shock is which result from the depletion and of intravascular volume, whether it is by extracellular fluid loss or blood loss. And then if the body will be tried to compensate by increase the sympathetic tone, which result in increased heart rate, increased cardiac contractility and peripheral vasoconstriction. As the word okey ke doktor?
Okey, suara tak?
Sekarang okey tak?
Sekarang okey. Dia kejap-kejap dia macam putus-putus.
Suara. Sekarang
okey. Sekarang okey.
Putus
Anis tengah berjalan kat mana? Macam telefon bukan terbalik je.
Dr. Aisyah punya line dia slow sikit.
Dia dekat mana? Aisyah dekat mana?
Dekat rumah.
Oh, kat rumah. Okey, ingatkan dekat sini. Kalau dekat sini, mainlah kat bilik saya. boleh dibantu ke kalau tak dibantu kita hari lain je lah. Takkan nak kena kena duduk atas beranda ke, kalau duduk bertingkik kat beranda ke, kalau tak boleh hari lain.
Sekejap.
Ha.
Kita ada tu sekarang.
Dengar?
Sekarang kita ada.
Okey. Bolehlah.
Okay. Sorry, internet problem. Slide nampak tak?
Nampak?
Ya.
Okey.
Okay, saya start balik ya.
Okey.
Okay, shock. I will present a topic of hypovolemic shock. Shock is the emergency condition lah where there is severe impairment of tissue perfusion which lead to cellular injury and dysfunction. And there is rapid early recognition and treatment to prevent the irreversible organ damage or death. And if left untreated, this patient can develop ischemic injury of vital organ which lead to multi-organ failure lah. Next is the phytophysiology. Hypovolemic shock is a result from the depletion of intravascular volume, whether extracellular fluid loss or blood loss lah. And then the body will try to compensate by increasing the sympathetic tone, which result in increased heart rate, increased cardiac contractility and peripheral vasoconstriction. And as the volume status continue to decrease, the systolic blood pressure will drop, which result in oxygen delivery to vital organ unable to meet the oxygen demand. And then normally we will our body will produce ATP by the aerobic metabolism lah. And then because of this, it will switch to anaerobic metabolism, which result in lactic acidosis. As you can see in shock patient, they will be high in lactate lah. And then there will be a sympathetic draft increase. The blood flow is diverted from the other organ to preserve the blood flow to the heart and the brain. This is the phytophysiology of hypovolemic shock. Happen when there is a hypovolemia, which will decrease the venous return and reduce the preload lah, and reduce the cardiac output. And then you can see the patient will be presented with hypotension, and there will be perfusion failure and tissue hypoxia. If untreatable, it will lead to organ dysfunction and multi-organ failure lah. And then the important equation in hypovolemic shock is cardiac output, which equal to stroke volume times heart rate lah. In hypovolemic shock, there will be reduced cardiac output, so you have to increase either stroke volume or heart rate. Next is the categories of shock. In hypovolemic shock, there will be decreased preload, increased systemic vascular resistance and reduced cardiac output lah. And the causes, as you can see, is mostly because of hemorrhage, GI losses, spacing or burns. Next, we'll go to the management. First one is when the patient come, history taking lah. You have to ask the patient, for example, the patient has GI bleed, presented with hematemesis. From the history taking itself, you can anticipate a shock.
Okay.
Next, we proceed to physical examination lah. Assess the mental status. If the patient drowsy, that means there might be a blood loss lah. For example, patient GI bleed. And signs of dehydration, urine output and CCTVR lah. And next we can proceed to our investigation such as baseline, ABG and DSM if required. ECG, turak cardiogenic shock, radiology, chest X-ray, fast and echo lah. This is the CCTVR. We assess the patient as presented lah. Scan to look for the fluid collection. And we can assess the IVC lah, whether normal IVC around 1.5 and in collapsible IVC you can see whether it will be collapsed IVC or dilated IVC in a patient with the fluid overload lah. And then IVC is one of the method whether we can use to assess if the patient have adequate resuscitation or not. Next is a class of hemorrhagic shock. This is we have to remember by heart actually. First one is you can see the important thing is that you have to remember the pulse rate, the vitals lah, pulse rate, blood pressure, respiratory rate and urine output lah, the most significant vitals. For example, in class 1, there will be pulse rate less than 100, blood pressure normal, and normal urine output lah. And then usually in class 1, we resusc by crystalloid only. And then for example, in patient in class 3, 4, maybe at that time we have to use blood products.
Okay, just go back to the previous slide. Okay. Slide yang ni is antara benda yang paling penting lah dalam bila kita bercerita pasal hypovolemic shock ataupun hemorrhagic shock. So you need to be able to identify patient ni duduk dalam class shock yang mana. 1, 2, 3 dan 4. Sebab this will determine your management. Macam Aisyah cakap tadi, kalau class 1, your choice of resuscitative fluid is usually crystalloid or mungkin tak perlu pun. Class 2 ni you dah need to consider blood product. Class 3, this is where you ask for your saline cross match. And class 4 is when kalau you identify your patient ni dah class 4, you dah kena minta safe O. Okay, this is why it's important for you to be able to recognize patient ni dalam kelas berapa. And it will also help with your communication lah. Kan, call, hi, I've got one patient intra-abdominal injury in class 4 shock. Sepatutnya it would trigger lah primary team untuk tengok patient dengan lebih cepat. Okay, so and kalau dah identify patient class 4 shock, you need to minta safe O. Dah tak boleh dah nak full cross match, tak perlu tanya dah full cross match apa semua. And what you also need to realise, class 1 and class 2 ni adalah kadang-kadang patient yang nampak okay je, tapi the changes in the vital signs are quite subtle. Okay, you need to recognise this patient early lah, sebab you need to start resuscitating the patient. And the other important thing about this classification, this only applies for patient yang youngish lah, dalam 18 to 50 with no chronic medical illness. Extremes of age, maksudnya patient pediatric or patient neonate or elderly, this table might not apply very well because these people, physiologically they are very different. Elderly ni kadang-kadang they've got hypertension, diabetes, other chronic illnesses, and they are on multiple medication. So they might not fit into this class 1, 2, 3, 4 sebab mungkin the hypertension tu akan mask the hypotension kan. BP normally dia 170. They present with BP 110. So awak kata 110 is normal BP. Or they are on beta blocker. So dia takkan become tachycardic. So take this table with a pinch of salt lah. It only applies to a certain group yang ideal lah. Patient muda, no medical illness. Patient with extremes of age, you need to assess the patient more carefully lah. Have higher index of suspicion. Jangan bergantung sangat. Oh, tak apa, tak tachy. So, it's not in shock. No. Patient extremes of age, be careful. Okay, this only applies to young, no patient with no medical illness. Okay. Carry on.
The next is management of hypovolemic shock lah in trauma patient. As first one, to do the primary survey lah when patient come to us, assess the airway, breathing, circulation, disability, exposure and jam lah. And then to see whether patient in shock or not. Then we proceed to the secondary survey lah. And then the secondary survey, we have to look for the external causes. If there is bleeding, source of hemorrhage, long bone, for example, long bone fracture. At that time, you have to anticipate blood loss lah. And then chest X-ray, abdominal, do the fast scan and X-ray that needed lah. And then before proceed with further intervention. Depends on the injury lah. There's 4 algorithm for assessment of trauma patient. First one is ABCDE, and then we proceed to the important one is fluid resuscitation lah. The first one we have to give when patient come, there's anticipate the shock, hypovolemic shock, and then we have to give fluid volumes 500 crystalloid lah over less than around 10 to 15 minutes. And then reassess the patient. Assess the patient. You can give the bolus 500 crystalloid up to liters, if I'm not mistaken, up to liters. And then again you have to assess the patient. And then if patient still in shock, we have to consider products. Next is the routine maintenance. If the maintenance depends on the requirement. And the replacement and the redistribution depends on the condition itself. And what happened in hypovolemic shock, not all patients can be resuscitated by fluid lah. Only as the doctor said earlier, those hemorrhagic shock only apply in normal patient. But if patient, for example, if patient in underlying IHD, CKD, we cannot give the fluid because it can cause the fluid overload. So we can consider using the inotropes.
Tapi ni kena jangan confuse shock, hypovolemic shock dengan shock yang lain. Hypovolemic shock, the treatment is replacement lah. The principle untuk hypovolemic shock is replacement. Kalau dia panggil dia prinsip dia replace like with like lah. If hypovolemic shock secondary to hemorrhage, patient trauma, bleeding, there's no role for vasopressor or inotrope. You have to replace with blood and definitive treatment. Surgery ke apa semua. All this is just to buy time je. So sama juga kalau patient hypovolemic shock secondary to say AGE lah. The treatment is not inotrope. The treatment is still bagi fluid. So shock yang lain, yes. Tapi kalau bila you cakap pasal hypovolemic shock, you need to settle the hypovolemia. Even kalau tengok yang slide yang Izzah present tadi pasal septic shock, first you kena tackle the hypovolemia part with giving adequate fluid replacement. Then you go for inotrope. So kalau patient tu memang clearly identified as hypovolemic shock, memang dia bleeding, say putus kaki, accident kan, blood kan. So your treatment is to replace the lost blood and to stop the bleeding, bukan start inotrope. So kena be careful pasal bila cerita pasal inotrope dalam hypovolemic shock. Sebab kena bezakan, hypovolemic shock ni dia nama tu itself refers to shock sebab patient ada blood loss. So in hypovolemic shock, secara teori dia, kalau awak start vasopressor or awak start inotrope pun, it's not gonna help because there's no circulating volume. So awak say even awak start dobutamine kan, the heart contracts harder, tapi there's no blood dalam vascular punya space untuk circulate. So tak guna. So you kena bagi fluid replacement. So ni pun dia cakap, shock with ongoing hypoperfusion despite fluid and vasopressor therapy. Maksudnya dah bagi fluid cukup, yes. Tapi maksudnya benda tu dah settle lah hypovolemic shock. So kalau hypovolemic shock per se, it's kena replace the volume. Fluid, kalau patient hilang fluid, say patient AGE, dia hilang fluid, gantilah crystalloid ke dan sebagainya, dan correct the electrolyte dan sebagainya. Tapi kalau patient blood loss, hemorrhage, you need to replace with blood. Dia prinsip dia replace light with light. Lost blood, ganti blood. Lost fluid, ganti fluid. So kalau dalam hypovolemic shock ni, patutnya slide pasal inotrope or vasopressor ni last sekali. Dia tak boleh mention in between. Okay. Carry on.
The next one is fluid responsiveness. This is depends defined by there is increase of stroke volume. The patient receive with 500 ml crystalloid over 10 to 15 minutes, as we can see in our first second algorithm tadi lah. And then the definitive test fluid for fluid responsiveness is a fluid challenge lah. And then fluid responsive patient have preload reserve and will have increased in stroke volume and will result in increased cardiac output when the fluid is administered. And the presumption is that increased cardiac output will lead to increased oxygen delivery lah and increased tissue oxygenation. And the patient should only receive fluid boluses if the hemodynamic benefits are likely to outweigh the risk of becoming overload. And as stated previously, the effect of fluid boluses are short-lived and minimal, and continuous fluid resuscitation in this patient will cause the fluid overload. These are the ATS classification based on the fluid resuscitation lah, whether there's three category, which is responder, transient responder and non-responder lah. And then the responder will respond to the fluid volume, which should increase and sustain improvement in blood pressure. While the transient responder will show the increased blood pressure but will followed by the recurrent hypotension. That means the patient still have actively bleed, and we may consider the blood transfusion. And then the third category is a non-responder, which is no improvement in the blood pressure. And then you have to rule out the other causes of shock.
Okay. So ini berbalik kepada apa yang saya cakap kat awak tadi. Kalau patient trauma datang BP low, if you bagi adequate fluid resuscitation, at least rasa, dah replace fluid, at least dah bagi 20 ml per kg and patient doesn't seem to respond, you need to start thinking of other diagnosis. Macam patient bleeding tak stop lagi ke, ada tension pneumothorax ke, cardiac tamponade ke, spinal shock ke, bukan start inotrope. So kena fikir lebih sikit. Itu maksud dia. Bila bercerita pasal hypovolemic shock ni, inotrope tu last after you dah rule out everything. Sebab takut patient ada concurrent shock yang lain. Sebab patient lah, dia very rarely lah datang dengan satu problem kan. So tapi bila kita bercakap dalam konteks hypovolemic shock ni, you need to be able to identify kenapa patient, you need to settle the hypovolemic shock. Bagi anecdote, it's not the first line lah of treatment. Okay, carry on.
Okay.
Yang algoritma tu ambil kat mana?
Ni.
Ha.
Ni saya tanya
Yang warna-warni tu,
warna-warni ni.
Ha.
Saya tanya dia punya last presenter sebab saya tak sure dia punya ambil daripada mana.
Okay. So dia benda ni it's useful lah, tapi sebenarnya bila cerita pasal hypovolemic shock ni, biasanya orang akan fokus ke hemorrhagic shock lah. Sebab commonly what you see in ED ni, hypovolemic shock ni secondary to trauma, patient bleeding. So focus should be on trauma lah, especially the class 1, class 2, class 3, class 4 shock lah. Okay. Then next time kalau present pasal hypovolemic shock, you need to separate lah. Mula-mula ceritalah pasal hemorrhagic shock, kemudian ceritalah pasal hypovolemic shock secondary to losses, mungkin burns or AGE or apa-apalah. Sebab dia lain sikit je. In the end, prinsip dia you have to replace volumes lah in both situation. Tapi bila bercerita pasal trauma ni, dia usually specific sikit. Dia akan cerita pasal blood product kan. Sebab bila ada algorithm ni, dia macam campur trauma dengan non-trauma. So sebab tu bila awak present ni nampak macam lompat sikit. Atas slide 11-12 cerita pasal trauma, tiba-tiba slide 13 masuk macam non-trauma, slide 14 masuk trauma balik. So macam nampak melompat sikit lah cerita tu. So kena careful sikit. The slide ni dia macam, yang macam slide warna-warni ni dia macam in general hypovolemic shock. So kadang-kadang it's easier or less confusing kalau awak separatekan trauma dengan non-trauma bila bercerita pasal hypovolemic shock. Dia baru dia clear sikit. Dan of course lah, tulisan kecil-kecil, padat-padat ni tak nampak lah. Kalau pancar pun tak nampak juga. So anyway, any questions about hypovolemic shock? Ada soalan? Tidak ada soalan? Nak tanya Aisyah? Tak ada? Okay, Fiza? Fiza ada ke lagi?
Ya, Doktor.
Bukan Izzah, Hafiza, Dr. Hafiza. Dr. Hafiza ada ke lagi? Tak ada dah kot. Dr. Hafiza ada nak komen apa-apa? Tak ada dah kot. Dr. Hafiza mungkin berpuas hati lah. So, anyway, okay, thank you very much.
Hello. Hello, sorry. Ada tu yang suruh tambah partial and fluid responder sebab nampak dia dah campur yang benda lain lah. Kan? Hello?
Hello, dengar.
Dah yang pasal partial and fluid responder sebab kalau nak bincang pasal macam hypovolemia disebabkan kata coagulation, sebab dia bertindih dengan septic shock juga kalau nak kata nak sabitkan contohnya macam EGD tu. Jadi kalau betul macam Dr. Fairuz cakap, kalau kata hypovolemia most of the time kita fokus, kalau orang banyak discuss lebih pada hemorrhagic shock. And the important of identifying identifying possible patient ada ongoing bleed dan early blood product punya transfusion, early blood product punya replacement lah. Janganlah sampai, sebab tu sekarang kalau kata trauma, kita start fluid, kita pergi actually crystalloid 2 pints saja. Sebab kita nak macam dulu sebab possible dilution apa semua. Jadi kalau kata patient lepas 2 pints still hypotensive, we need to consider patient ada ongoing bleed and kena start early blood product punya replacement. Okay, masa kena transfuse blood. Sebab tu semalam saya kata you need to add regarding the partial and also partial or transient or non-responder untuk fluid responder. Okay, sebab kita nak make sure, untuk nak beritahu kawan the importance of cepat. Bukanlah semalam pun ada satu case UGIB, bukanlah sengaja nak membebel ke apa, tapi you need to remember kalau hilang blood macam Dr. Fairuz cakap, ganti dengan blood. So kalau you delay, you bagi ni bila kita dah start blood and then patient start already see, nampak sangat dia punya patient yang UGAB tu memang perlukan blood. So patient already in class 4 shock. So benda-benda ni jangan delay. Okay? Boleh lah? Ingatkan ada kes I think ada semana ada yang run full blood untuk regarding UGAB patient dekat critical tu. Ada apa? Saya rasa yang tu je kot. Fairuz?
Tak ada apa.
Okay. Okay, thank you for both presenter.
Thank you, doktor.
Okay,
Yeah.
thank you.
Thank you, doktor.
Okay, thank you.